Yeah, we like. Hello, dear students. Welcome to the PW MedEd NExT. This is Dr. Santosh Patil, your faculty for medicine. And with us today, we have got Dr. Ranjith for pathology and Dr. Ankit for the pharmacology. So we are today having a truly integrated session discussing the neurodegenerative disorders. When I say neurodegenerative disorder, obviously Alzheimer's disease and Parkinson's disease comes to your mind, and those two diseases will be our focus areas. Now, before we begin with the session proper, let me give you a template of how we study neurodegenerative disorders. Number one, when I say neurodegenerative disorders, it means neurons in some part of the brain are getting degenerated. So what we should know, why are they getting degenerated? Generally, they're getting degenerated because of accumulation of some misfolded proteins or abnormal substances. Then you should ask the question, what are those abnormal substances? And if there are abnormal substance accumulation in neurons, can we see it under microscope? If we can, then what are those inclusion bodies called as? Number two, where the degeneration is affecting, what is its functional anatomy of that particular area, so that you can expect what clinical symptoms to see. After that, you should concentrate on the pharmacotherapy and diagnosis. Obviously, when it comes to diagnosis, question number one is, do we need biopsy? Is there anything specific imaging finding that can help us diagnosis, or is it only clinical? And when it comes to pharmacology, two important things to remember. Number one, it is a neurodegenerative disorder. Is there any drug which can slow down the progression of neurodegeneration? Number two, how can we make the patient's symptoms better? This will be the template for learning neurodegenerative disorder. With this introduction, we will first start with the Alzheimer's disease. So when we say Alzheimer's disease, the first thing that comes to our mind is memory deficit, right? But we also quote that Alzheimer's disease is a disease where there is dementia. The confusion among students' mind is dementia and memory deficit equal? The answer is big no. Memory function is only one part of the cognitive function. When someone loses cognitive function, we can say there is a cognitive disturbance. Again, loss of cognitive function is not equal to dementia. So let me pose a question. What is dementia? What is mild cognitive illness? So number one, when any of these cognitive domains include memory, thinking, reasoning, and various other thought processes. So when any of this cognitive domain is affected, but it is not causing any impact on the patient's quality of life, we call it as mild cognitive illness. How do we get to know whether patient has got mild cognitive illness? Mostly patients don't come to us with symptoms of mild cognitive illness. These are unearthed or unmasked on using the tools which are used for assessment of the cognitive function. So then is the question, what are the tools which are used for assessing the cognitive function? Most commonly, what do we use? Mini mental status examination, MMSE. So if you do MMSE of somebody and it is lower than normal, then you can say there is mild cognitive illness, provided patient has no impairment of the quality of life. When mild cognitive illness progresses to impair the patient's quality of life, that is when we call it as dementia, right? So memory is only one part of the cognitive function which can be impaired, but impairment in other cognitive domains can also be contributing to dementia. That's the first take-home message. So now we have understood what is mild cognitive illness and what is dementia and the difference between these two. Now, when I say dementia, is it only about Alzheimer's disease, or there are other causes for dementia? The most important thing we have to note here is that dementia can be reversible. It is not always irreversible. There are plenty of causes of dementia which are treatable or reversible. And this is again an important MCQ area. What are the causes for reversible causes for dementia, right? So let me give you some clues and tell me what comes to your mind. Okay, so if you do not study well now, and if you give your exams and don't do well, then you take it to drinking. And once you take it to drinking, over the time, you can come back with this syndrome where dementia is one of the feature. So what am I talking about? Alcohol and cognitive function. Let me give you a little more clues. In this disorder, you can develop confabulation. What is confabulation? When you have deficits in your memory, you try to fill it up with your made up stories. That is what we call as confabulation. You can also have internuclear ophthalmoplegia. So what am I talking about? Right, Wernicke-Korsakoff's syndrome. Why is it? It is due to thiamine deficiency. So thiamine deficiency is one reversible cause for dementia. Let me tell you about one more condition. I'll give you a clue. So this is again a nutritional deficiency, where you remember the disorder with the 3Ds, and one of the 3D is dementia. So what am I talking about? Right, I'm talking about pellagra, diarrhea, dementia, right? And this is pellagra is due to niacin deficiency. So niacin deficiency is one more cause for dementia, which is reversible. Okay. Then there is an endocrine disorder which can lead to reversible dementia. And if you miss the diagnosis, you are pretty much liable to be sued by the patient later on. What am I talking about? Right. Hypothyroidism is one more reversible cause for dementia. Why understanding reversible causes for dementia is important? Because we should not misdiagnose reversible causes of dementia as Alzheimer's or other irreversible causes for dementia. This is a basic thing that we should know. Every time you make a diagnosis of dementia, you should do these basic investigations, nutritional profile and endocrine profile, so that you don't miss a neurodegenerative disorder, you don't miss a reversible cause for dementia. Okay, so with this basic understanding, we'll start with the first neurodegenerative disorder for today, that is going to be Alzheimer's disease. Okay, so let me give you a brief introduction to what is Alzheimer's disease, and then Dr. Ranjith will discuss about the pathology of Alzheimer's disease. Now, when we talk about dementia, we say senile and pre-senile dementia. So some dementias which become evident after 60 to 65 years of age, we can call them as senile dementia. And those dementias which are evident before the 65 years of age, we call them as pre-senile. So Alzheimer's is a senile dementia. So if I say age is a risk factor for Alzheimer's disease, I'm making a perfect sense, because as you age more than 65, your risk of developing Alzheimer's disease keeps increasing. So age is a single most important risk factor for the Alzheimer's disease. Now, in Alzheimer's disease, the neurodegeneration is predominantly affecting the temporal and frontal lobe. It mostly starts in the temporal lobe. And if you remember, in the very first integrated session, we discussed about the functional neuroanatomy and its clinical correlation. There we learned about the role of temporal lobe. Temporal lobe plays an important role in the function of memory. What is the important role played by the frontal lobe? Frontal lobe plays important role with respect to, when it comes to the functional neuroanatomy, it plays an important role with respect to patient's personality and behavior. Apart from that, yes, there is the motor area in the frontal lobe, there is a premotor area that we have already discussed. So the prefrontal lobe is concerned with personality and behavior. So when the degeneration starts in the temporal lobe, the earliest symptom of Alzheimer's disease is going to be the loss of memory. And we already know that the loss of memory will affect first the short-term memory, and as the condition progresses, the remote memory will get affected. And when the degeneration spreads to the frontal lobe, we can also start seeing the behavioral changes in patients with Alzheimer's disease. Why this is important for us to understand? Because there is a differential diagnosis to Alzheimer's disease, which is frontotemporal dementia. Frontotemporal dementia, number one, it is a pre-senile dementia. Most of the times in 50s, we end up making a diagnosis of frontotemporal dementia. And in the frontotemporal dementia, there are two variants, and the common variant is called as behavioral variant, where the degeneration starts in the frontal lobe. Eventually, the temporal lobe is involved. So in those patients, the earliest symptom will not be memory loss, but rather the earliest symptom will be behavioral changes. That is also a dementic condition. Okay. So with this basic introduction, let us see why there is neurodegeneration happening in Alzheimer's disease, where and what are the microscopic changes we would be seeing. Over to you, Ranjit sir.
Okay, thank you, Santosh, and thank you everyone who is there. So hi to everyone who is live. Santosh did ask lots of questions, and I want you to comment. It's not about being right or wrong. One thing which I'm sure is every medical student, while reading Alzheimer's disease, at least at one point of time, you must have thought, am I suffering from Alzheimer's disease, right? Because almost everything we read definitely vanishes from the head, right? So we are not suffering from, fortunately not suffering from Alzheimer's disease. But yes, as a pathologist, my role in diagnosis of Alzheimer is almost nil, because no one is going to take a biopsy of Alzheimer's. But still, people do ask microscopic finding of Alzheimer in MCQ. When you become the professor who is going to ask MCQs, please don't ask these, because that's not required at all. If I know how Alzheimer's happens, there is few genetic importance which is coming into play, especially with the genetics being available to everyone over the counter. They are saying that, okay, am I at risk of Alzheimer's? Like Santosh said, it's going to be seen above 65 years. So there are few familial predisposition of Alzheimer's which can happen early, right? So genetics and understanding genetics is important. If anyone know any gene involved in Alzheimer's, you can comment, and we'll be definitely going with the pathogenesis, right? So the most important thing for me for Alzheimer's disease is amyloid precursor protein. That's the one of the important thing, because it's an amyloid condition where my amyloid gets deposited in the brain. It's causing destruction or abnormal function of the neurons. That's what is going to result in Alzheimer's disease, right? So next slide, sir. So if you look at the amyloid precursor protein, there are multiple things here. Okay, sir, it's a bit blurred. Can we make it dark? Is it possible, sir? Completely white.
It's completely white.
Yeah. Okay, so this is an image from Robbins. I'm just going to tell you what happens in this thing. Look at amyloid precursor protein.
Just give me a second.
Sure. So if you look at the amyloid precursor protein, it's normal transmembrane protein, like multiple proteins, like a coupled receptor or something like that, right? So we have any protein in the body, right? So what is the destination? Once the protein's function is over, the protein has to get destroyed. That's obviously the destination for any protein, whatever you're going to see. Still dark? Okay.
Maybe we can reduce the screen brightness.
Fine, this is fine. So if you look at this is actually the amyloid precursor protein. You can see on the top, the curved one, that's the APP or amyloid precursor protein. And it also has a transmembrane part, the red one and the yellow one, and a carboxy terminal, which is there inside the cell, right? So this protein, once the function is over, this protein should be destroyed. Anytime, any protein in my body will be destroyed, right? In the corner, you can see there's a beta secretase activity on the top. There's an alpha secretase there. And then if you look at the below, there's a gamma secretase, right? So these are the three secretase activity, which is going to destroy the protein. Let's see how it gets destroyed for you and me, presuming we don't have Alzheimer's, right? So a little bit below. So there's below, sir, there's something called written as non-amyloidogenic, right? If you look at this, normally how a protein gets cleaved is, there's a site of cleavage. You have the red one which has been cut in the middle, along with the soluble fragment of APP. Because of the alpha secretase activity, it gets cut there. And below, the gamma secretase activity cuts the carboxy terminal, right? So what happens is, this is entirely soluble. So protein is formed, does its function, the cell becomes old, the protein is destroyed, and it will be dissolved, it will be used again, right? Like any other protein in my body, it is going to be reutilized. But there is a possibility, sometimes I can have misfolded protein, which means it's not cleaved properly, right? That's my amyloidogenic pathway. Can anyone comment what is amyloid? So if we can go to the amyloidogenic pathway, right? So if you look at this amyloidogenic pathway, it's the same protein, but the site of cleavage is different. So I have a beta secretase activity, which takes the amyloid precursor protein alone outside. And then I have the gamma secretase activity, which cleaves at the yellow and the red part, right? So because of this cleavage, I get something called an A beta. To be specific, it's A beta 42. That's the number of amino acids present there. If it's A beta also is fine. To be specific, it's A beta 42. So this A beta 42 is not going to get destroyed. My ubiquitin proteasome pathway cannot destroy it. So over the period of years, now let's say a person lives for 120 years, definitely the chance of this A beta, even without familial predisposition, will be there. That's why its age is the most important risk factor of amyloid. If I live for 40 years, I might not have A beta. If there's no familial predisposition, I might not have. If I live for 90 plus years, definitely the chance of this A beta accumulating will be more, right? So my body cannot destroy this A beta. So this A beta keeps on accumulating in the brain, right? Oligomers, then polymers, right? Once it starts accumulating, it forms two important structures. There are multiple things which will be given in Robbins, but two important things are more than enough for us, right? So can you go scroll a little bit down? If you look at this, there is something called a neurofibrillary tangle and your plaques. The plaques and the tangles are the most important thing. These A beta amyloid fibrils form the plaques. What happens? Tangles are more important because tangles have something called a tau protein, tau phosphorylated protein. It's there. There are two things here. You can see them. There's plaques and tangles. The tau thing which gets aggregated is forming the tangles, and the amyloid, just the amyloid, is forming the plaque. What is said over the period of research is the amount of tangles determines the cognitive decline. More and more tangles are present in the brain, the cognitive decline becomes more prominent. Plaques are not important for me. Plaques has more amyloid, right? So the amount of tangles is equivalent to the cognitive decline. This can come in a prospective MCQ. Okay, so just zoom out. So this is what happens for a normal APP. Now let's see what will happen if there's a familial predisposition. We know normal, right? So if I say, if the amount of APP produced in any one of us is more, let's say I'm producing normally 1 unit of APP, but I'm producing 10 units by mistake. Is there a possibility the non-amyloidogenic can become more? Yes. If you are live, I want you to comment. If I'm producing more and more APP, is there a possibility the non-amyloidogenic A beta protein can become more? Yes. And APP is seen in chromosome 21. What disease comes to your mind when you think of trisomy 21? I'm sure you know this answer. I want you to comment, right? Perfect, Rajat. Rajat said, yes, it will happen. I want you guys to comment here. So what disease comes to your mind when you have trisomy 21? Because APP is seen in chromosome 21. Normally you have 2 chromosome 21s. If you have 3 chromosome 21s, the amount of production of APP will be more, right? So Down syndrome. Down syndrome, definitely there is a risk of your Alzheimer's disease, right? That's all. So when I have more APP produced, the risk increases. I am not saying that every Down's baby will have Alzheimer's, but definitely compared to normal person, the risk is definitely higher, right? The next thing, there's 2 chromosomes written called as PSN1 and PSN2. If you remember the cleavage part of non-amyloidogenic pathway, the gamma secretase activity, if it's more predominant than my beta secretase, it becomes amyloidogenic, right? So this PSN1, PSN2 mutations increases the gamma secretase activity. So again, from becoming a soluble protein, it's pushing them to your insoluble protein, which is amyloid, right? So that also predisposed to amyloid protein, right? And there's a polymorphism called as ApoE4. This is particularly very important because it's gathering lots of attention in recent medical science, and there are genetic tests which can test ApoE4 with you, right? But please don't test. If you have an ApoE4 polymorphism, doesn't mean again you will have Alzheimer's. It increases the risk of Alzheimer's because ApoE4 increases the deposition of tau phosphorylation. So when tau is more, the tangles are more, definitely the cognitive decline is more, right? So these are few things which can genetically predispose to Alzheimer's disease, right? That's about the pathogenesis. So next slide. These are images from Robbins. The top 2 images are nothing but your amyloid fibrils. You can see there it's in the first one, which is being mentioned as A. You have a little bit of arrow marks where you can see the amyloid is a protein. It's going to be pink in color. That's all, right? So, and the bottom one and the right side, you have the amyloid stain, which makes it brown in color. That's all. In the bottom one, there are 2 images in the bottom where you have flame-like structure. That's the tau aggregate. Whenever tau is equivalent to tangles, T40, and this tau aggregate is the one which is going to help in the cognitive decline, and more tau it's there, more and more decline is there. However said and done, no one does biopsy for Alzheimer's. If someone is going to do biopsy for Alzheimer's, I would say the doctor is having Alzheimer's, right? Because no one ever in their common sense is going to do a biopsy for Alzheimer's. All these are more of research things. Maybe when Ankit says going to introduce few new drugs, I need to know whether the drug is working or not. For that, yes, I need to have an evidence. That's a place where the microscopy of Alzheimer's is going to come, right? So over to Ankit sir, tell the students like what are the drugs available, new drugs and old drugs.
Thank you, sir. So let's come to the pharmacotherapy, which drugs we give. Remember, Alzheimer is a potential area. If you make a very good drug, you will be the fastest millionaire in the world. You will become the fastest millionaire in the world because there is a huge unmet need. So it means that we don't have very good drugs which can reduce or retard the progression of disease. But yes, we have drugs which can provide symptomatic improvement. But can we stop Alzheimer's disease? Till now, the big answer is no. But recently, I will tell you some new drugs came, which have shown a little bit of promise. So let's jump over to the pharmacotherapy of Alzheimer's disease. So the first class of drug, which I'll show you, is anticholinergics. So these are the oldest class of drug, anticholinergics. So anticholinergics, they inhibit the degradation of acetylcholine. Hence, the level of acetylcholine in the brain will increase. And remember, acetylcholine, especially in hippocampal area or nucleus of Maynard, it improves memory. Hence, overall, memory will not be a right word to use. It's better to use a word cognition. So it improves cognition. Now, if a person is still having not desired improvement, or if we can say the cognitive symptoms are severe, like sir has explained, they are associated with behavioral abnormality. How you will assess? you will assess by MMSE, that is Mini Mental Status Examination. If the score is still less than 18, that means there is severe cognitive decline. In that case, we add a drug to anticholinesterase, and the drug name is memantine. Now, how we can remember the name of this drug? Remember the first three drugs, MEM is coming. MEM word is coming. That means it improves memory. And the next word A is coming. It is given in Alzheimer's disease. So this is a trick how you can remember the name of a drug, memantine. Now, how memantine acts? Memantine actually blocks a receptor of glutamate. The receptor name is NMDA receptor. And there is a hypothesis that when glutamate level increases, glutamate is an excitatory neurotransmitter. So when there is excess of excitation, because of so much happiness, the neurons die. So that is why we want to block the glutamate receptors, and the next approved drug is memantine. Now, recently in this year, 2023, we got 2 new drugs for Alzheimer's disease. Let's first jump over to the names of those drugs. We can see the name, Aducanumab. So this drug you have to remember, and it might be asked in your exam. Now, first, what is this Aducanumab and lecanemab? Now, these two MABs means they are monoclonal antibody, and these monoclonal antibody, they target beta-1 amyloid protein, which is deposited in the brain, and it helps in removal or clearance of this beta-1 amyloid protein. Now, how we can remember the name of Aducanumab? You can see AD word is coming. AD stands for Alzheimer's disease. And you can see U word is coming. So it's an monoclonal antibody which is targeting beta-1 amyloid protein. So can we say beta-1 amyloid protein is the main underlying mechanism which causes Alzheimer's disease? Hence Aducanumab and lecanemab. Remember the name Aducanumab, AD for Alzheimer's disease. Now we tried many drugs, but we failed more than we succeeded. So I'll just show you a slide of failed therapy. You don't have to remember them. What you have to remember is this class of drug which is written in front of you. But we tried many drugs. So before coming to those drugs, let's write the names of anticholinesterase, which increase the level of acetylcholine. The mnemonic to remember is, you can write T-Duggar. T stands for tacrine. Tacrine was the first drug to be made for Alzheimer's disease, but unfortunately it got banned. So now the approved therapy, the approved drugs we are having is only Duggar. And among them, donepezil is considered to be the drug of choice for Alzheimer's disease. It is the first drug to be started. The reason is it is the most effective drug. Now the question is why tacrine got banned. Remember, tacrine was a very short-acting drug. It has to be taken multiple times a day. Now just imagine, एक आदमी जिसको भूलने की बीमारी है, a person who has a habit of forgetfulness, would you like to give a drug which is given multiple times a day? The answer is no. Hence, it was a short-acting drug. And the second reason why tacrine got banned, it was hepatotoxic also. Hence, we have donepezil. The reason is donepezil is the longest acting drug. Because of its long duration of action, it is the most effective drug for Alzheimer's disease. But recently, we came up with a great idea. Why to give an oral pill? Let's give a transdermal patch so that a person does not have to take a drug again and again because the person forgets. Hence, we have transdermal patches of rivastigmine available. So this is a very important MCQ. You must remember. Now, in one word, what are the side effects of anticholinesterase? Remember, anticholinesterase, they increase acetylcholine level, and acetylcholine increases all secretions of the body. Just remember a mnemonic, dumbbells, and increase all the secretion. So can we say D for diarrhea, U for urination, E for emesis, L for lacrimation, S for salivation and sweating. Now, acetylcholine suppresses heart, which can lead to bradycardia. It can provoke asthma. It can cause bronchospasm. And in eyes, it can lead to meiosis or pinpoint pupil. So remember a mnemonic, dumbbells, these drugs side effect. Now, these are the therapies which we had developed for Alzheimer's disease. but we drastically failed. So the first one with unproven benefit is Mediterranean diet and eating a lot of fish like omega-3 fatty acids. Then it's a very common saying, the person who smokes suffers less from Alzheimer's disease. Probably he might die a little bit earlier because of lung cancer.
Other diseases.
A person might die a little bit earlier because of lung cancer. Probably he might not be able to see the development of Alzheimer's disease. So the reason is very simple. Nicotine is just like acetylcholine. Nicotine improves memory. That is the reason. Now, vitamins, they are given, but no benefit. So Alzheimer is much more, you can say, hard to treat. Then we tried it with some more homemade therapies like ginkgo biloba. Aspirin was started, statins, some ergots, piracetam, citicoline, which is our derivative of nicotine, all failed. Don't worry, you don't have to remember. We also went too ahead with pathology. We started at making gamma secretase inhibitor, which sir has recently explained you. We tried to inhibit this gamma secretase so that this proteins, tau, all those things should not be produced. And these drugs, they ended with the word cis-chat, but again, they miserably failed. So you don't have to remember the name. So remember anticholinergics, memantine, and Aducanumab. 3 drugs, simple, keep it simple. This is the therapy we have for Alzheimer's disease. So now, Santosh sir, any final words?
So just few points to add, guys. Number one, Ranjith sir has already told you that there is no role of a pathologist when it comes to the diagnosis of Alzheimer's disease. The question is, we know what is the pathophysiology, we know what are the microscopic findings, and there are also special stains to stain the amyloid. When we have all of that, then why are we not utilizing the pathologist for the diagnosis? The answer is very simple. When it comes to diagnosis of any disease, we always weigh the risks and benefits involved. And there are few things which make the diagnosis of Alzheimer's disease extremely easy for a practicing clinician. What is that? If there is an MCQ asking you what is the most common cause for dementia, right? What should be your answer? Similarly, if there's a question asking you what is the most common neurodegenerative disorder, what should be your answer? For both of these, your answer should be Alzheimer's disease. Alzheimer's disease account for 60 to 80% of dementia cases who are above 65 years of age. You take into account any geographical location. So that makes, if you are making a diagnosis of Alzheimer's disease in 100 patients, right, you will be correct in at least 80% of the cases. Only in 20% of the cases, your diagnosis may be wrong, right? So there is a statistical favoring towards the diagnosis of Alzheimer's disease in any case of dementia. So all we need to do is, number one, rule out the reversible causes of dementia. We have already made a list of few important reversible causes of dementia. Number two, if it is a pre-senile case, age less than 65 years, only in those cases you might need to do some additional steps. What additional steps generally we do? We do a brain imaging. Now, what am I interested in looking at when I do the brain imaging? If you're looking at simple MRI, in Alzheimer's disease, we have already agreed that the neurodegeneration first begins in the temporal lobe and then eventually the frontal lobe. So in Alzheimer's disease, early on in the course of the illness, we might see the temporal lobe atrophy. The frontal lobe may not be largely affected in the initial stages. The closely related differential diagnosis was frontotemporal dementia, where the neurodegeneration starts in the frontal lobe, eventually in the temporal lobe. So very commonly, we see frontal lobe atrophy in the frontotemporal lobe dementia patients. So imaging can help you to distinguish between these two conditions. And also a good clinician can make a little bit of clinical judgment. Frontotemporal dementia patients might have motor symptoms, which are usually rare in Alzheimer's disease. What motor symptoms are common in frontotemporal dementia patient? If you remember when we have discussed earlier also in various situations about the motor neuron diseases, we have discussed frontotemporal dementia along with the motor neuron disease. Which motor neuron disease I'm talking about? Can you comment and tell me which motor neuron disease can be associated with frontotemporal dementia? I will give you a clue. This is one motor neuron disease where both upper motor as well as lower motor neurons are affected. Let me give you one more clue. Right, a very famous space physicist was affected with this disease.
ALS.
Stephen Hawking was affected with this disease, right? Amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis can be associated with frontotemporal dementia. So if you have a patient with motor symptoms start thinking more towards the frontotemporal dementia than Alzheimer's disease. So there are some clinical judgments to make, but diagnosis remains clinical. You can take the help of imaging, which is not required in most cases. The biopsy, as Sir told, it's only concerned with the research, right? When you need to document or you need to understand the effect of drugs in the progression of disease, we go for the biopsy. Okay, so with this input, we will now move on to
I want
the
to add
next neurodegenerative disorder. Yes, sir.
that there are recently a new drug approved for ALS also.
Yes, sir.
Earlier, there are only 2 drugs approved for ALS.
Yeah.
Sir. The first one was Riluzole.
Yeah.
So just like memantine, Riluzole is also an NMDA antagonist. So remember, ज़्यादा खुशी के मारे neurons मर जाते हैं. When neurons becomes very happy, they die. So it blocks glutamate receptor. Glutamate is an excitatory neurotransmitter. But recently, 2 years back, sir, one more drug got approved. I think 3-4 years back, the year when Stephen Hawking died, actually.
Yeah, okay.
So in that year, the question was asked about the other drug which is approved for ALS. And the drug was edaravone. It is an antioxidant molecule. So just remember, only 2 drugs are approved for ALS. Remember Stephen Hawking. Now the question is, are they very effective drug? I would say no. Otherwise, Stephen Hawking would still have been alive, and he must have discovered some much other black holes and white holes as well. So back to you, sir.
Okay, so guys, we have already learned about Alzheimer's disease. Now we know what are the clinical features, how Alzheimer's disease is different from a closely related differential diagnosis, frontotemporal dementia. We are aware about the pathological findings, and we know how we manage these patients. So with this, we will move to the next neurodegenerative disorder, which is Parkinson's disease. Okay, so when I was talking about Alzheimer's disease, I told you it is the most common neurodegenerative disorder. And why Parkinson's disease comes right after it? Because this is the second most common neurodegenerative disorder. This is the second most common neurodegenerative disorder. Here also, when you study about Parkinson's disease, you can follow the same template. If there is neurodegeneration, what are the risk factors? Why the neurons are dying? Where are they dying? And if in a particular anatomical structure, the neurons are dying, what are the clinical manifestations arising out of it? And if you have to make a diagnosis, do we need a pathologist? Or is it only clinical, or do we need a radiologist help? And when it comes to management, do we have anything to slow down the progression of neurodegeneration? And what can we do for the patient's symptomatic improvement? That's the standard template. So let me tell you, the Parkinson's disease, the single most important risk factor for Parkinson's disease is again age. Most of the patients who are diagnosed with Parkinson's disease are 70 plus. At the time of diagnosis, they are 70 plus. But many of the patients who are diagnosed with Parkinson's disease, they are diagnosed when they develop motor symptoms. And they can have pre-existing other symptoms even before the motor symptoms develop. And we probably have to answer some MCQs on that. The examiner might ask you, what is the earliest symptom of Parkinson's disease, which is not tremor, which is not rigidity? Okay, so what is it? Probably we will discuss after we are done with the understanding of the pathology in Parkinson's disease. Similarly, the sequence of progression of symptoms, right? That is extremely important when it comes to making a clinical diagnosis. Okay, so what we will do is we will first understand what is the pathology of Parkinson's disease, and then we will discuss the clinical features. Over to you, Ranjith.
Okay, thank you, Santosh. So Parkinson's disease, my earliest memory of Parkinson's disease, my medicine OPD. Almost every subject, they have some tricks under the sleeve, right? So Parkinson's disease, I remember my PG telling a patient walking inside, that's Parkinson's, right? The stepping, the gait, all those things are very classical of Parkinson's. So why I told this was, even after finishing pathology and practicing, when I remember Parkinson's, the first thing comes to me is the pill rolling tremor and walking and stooping, which means, again, I don't have any role in the pathogenesis. But I wanted to add one important thing here. Parkinson's disease, over the period of years, there are lots of understanding which has happened. Maybe future that might change the course of Parkinson's treatment, maybe not, right? So whenever we were talking about Parkinson's disease, there are few environmental toxins, few pesticides, which are told to be involved in Parkinson's disease. The risk factor, like aluminum toxicity, may be associated with Parkinson's, right? So there are multiple places where they are not able to explain why and how this toxicity causes Parkinson, because they couldn't find a link. When I'm eating or when I'm inhaling or when I'm in contact with any toxin, how did it go to the neurons in the brain? So of late, last few years, with lots of research, they have diagnosed something saying that there's a gut-brain hypothesis, because this microbiome and gut-brain hypothesis being taught for multiple neurodegenerative disorders. There's an article 3 years back which says if you don't brush properly, you are at risk of Alzheimer's disease. There are lots of things which says that bacteria is responsible. So when you have any exposure of toxins, environmental or pesticide, all this alpha-synuclein, which is one of the important component which accumulates in your Parkinson's, is actually starting from the gut neurons. It's not affecting the neurons here first. It affects your gut neurons, and from those neurons they spread to your medulla, because it has to go via the medulla. In the brain, the first place where this alpha-synuclein is seen in the medulla, then it spreads to the neocortex, substantia nigra, and destroys everything, right? So ultimately, Parkinson is also a protein misfolded problem. I do have few genetic predisposition, but acquired cause is also there, right? I just want to say, for me, medicine is not just about the textbook. Medicine is very holistic. And I feel that India is one of the pioneers of medicine, because USA might lead medicine now, but it originated from India. I always feel that USA knows how to put an MRP to a drug and to sell a drug, but the knowledge is from us, right? So Ayurvedic treatment of Parkinson's, which is there 150 years back, is giving enema. Maybe 150 years back, I didn't know, where my forefathers knew about the gut-brain hypothesis, right? I don't know if they know. Again, biggest problem for us is neither my forefathers are good in documentation, nor we are good in documentation. We don't like documentation. So I do something without doing anything. So please start documenting. Maybe in future, this gut-brain hypothesis could get a Nobel Prize in future, right? Because when I give enema, all the toxins in the gut goes away. The bacteria gets flushed out. The neurons of the gut is not involved. If the neurons of the gut is not involved, there is no way alpha-synuclein can reach the brain and cause Parkinson's. That's how they were treating Parkinson's like 150 years before, maybe before even Harrison textbook of medicine came, right? So we are, the modern medicine is trying to change that, and hopefully it might change in future as well, because gut-brain hypothesis is very important for the future development of Parkinson, right? Having said that, the only thing what I'm going to see in microscopy is the accumulation of this protein called as alpha-synuclein. Sir, next slide, sir. Okay, so I have an image of alpha-synuclein, which was asked once in an exam. So if at all it comes, you should be able to know it. Again, this is not useful for diagnosis. There are few things called as alpha-synuclein and Lewy body, right? There's a microscopic slide.
Yes.
Right? It is there before Alzheimer's. So if you look at this microscopic slide, okay, this is a substantia nigra. You can see the melanin kind of a pigment there. So it tells me that's a nigrostriatal pathway neuron, right? And you can see a pink color accumulation inside that. That is your alpha-synuclein. And it's also, to prove this hypothesis, when you have an amplification mutation in the alpha-synuclein gene, yes, theoretically, and also maybe in few cases of Parkinson's, we find this mutation as well, right? So more and more alpha-synuclein accumulates inside the neurons. Any protein which is misfolded accumulates inside the neuron. It causes apoptosis. That's a basic problem, right? And if brain, CNS dies, I want you guys to comment, can a CNS neuron regenerate? Or brain, any brain cell in my body, does it have, or neuron in my body, do they have good regenerative capacity? The answer here is no, right? So when my neuron dies, it cannot regenerate. And till now, since my pathogenesis is not complete, I am not able to stop the pathogenesis. So Ankit sir will definitely take it over from here. There are huge number of lists of anti-Parkinson drug. Quite a few of them are symptomatic. I'm not able to stop it. And one by one, you'll have resistance. And over the period of years, there'll be more and more drugs involved. Maybe if I can complete the circle of pathogenesis, I can stop at some point of time, maybe reverse it. Or maybe Ankit sir has some new drugs which is involved in Parkinson's, which might help in the reversal of the disease as well. Hoping to happen soon. And like Santosh said, that it's purely a clinical diagnosis. Rajat has asked question, bradykinesia. How?
Yeah, I will address that. So before Ankit sir starts with the drugs, let us take a quick look at the clinical features. But before that, let me address a few points. Number one, the Parkinson's disease is a neurodegenerative disorder, which is not only affecting the dopaminergic neurons. So this is like a misconception among students' minds that when we talk about Parkinson's disease, it's only about substantia nigra. So the neurodegeneration affects the other neurons which are using the other neurotransmitters in their process. Okay. So the earliest site where we might see the neurodegeneration is in the anterior olfactory area and the locus ceruleus, which is part of the brainstem, like Ranjit sir told. These are the two structures where you see the evidence of the neurodegeneration beginning. Okay, now we have already learned about the neuroanatomy and we know the functions, right? What is the function of anterior olfactory area? Olfaction. And what is the important function of locus ceruleus? It is concerned with the autonomic nervous system, right? So from there, in stage 3, the neurodegeneration involves the dopaminergic neurons in the substantia nigra. So if I say that the earliest symptom of Parkinson's disease is anosmia or hyposmia, am I making the right sense? Right. So if there's a question asking you, what is the earliest symptom of Parkinson's disease? This is anosmia or hyposmia. It is secondary that patients don't come with that complaint to the hospital. Like at 60, we think that all our sensations are supposed to go berserk and we don't bring our parents to hospital because his ability to smell has come down, because mostly it is believed as part and parcel of aging. Only when they start developing motor symptoms, they are brought to the hospital for further evaluation. So at the time of diagnosis, motor symptom is the presenting complaint, but when you retrospectively ask them a question, they might come out with an answer saying, yes, he had lost the ability to smell for quite some time. And second, if the autonomic nervous system goes dysfunctional, what symptom we can expect? Let me give you a clue, right? In diabetes, there is autonomic neuropathy. What symptoms do we expect? Number one, we can expect postural hypotension. So patients might have history of falls because of postural hypotension before they came to us with the complaint of tremors or rigidity. Second, in diabetes, the autonomic nervous system dysfunction leads to diarrhea, but the vice versa or the converse can also happen. In Parkinson's disease, typically they develop constipation. I keep telling to students that you might give them a satisfactory result with their motor symptoms with all the fantastic drugs created in recent time, but they won't become happy with your treatment of their constipation. That's a very challenging symptom of Parkinson's disease. Okay, so these are the symptoms which predate the onset of motor symptoms. Clear? So the postural first symptom is anosmia or hyposmia, postural hypotension, and constipation. These are the pre-motor symptoms before the motor symptoms appear. And among these, earliest one is anosmia or hyposmia. Once the neurodegeneration spreads to the substantia nigra anatomically belongs to which part? It belongs to the extrapyramidal system. So for motor control, we have a pyramidal system and the extrapyramidal system. Pyramidal system is concerned with your voluntary movement, and the extrapyramidal system fine-tunes your voluntary movement. So if there is a damage to an extrapyramidal structure, either you can have movement disorders where there are abnormal movements, or you can have the abnormalities of the regular voluntary movements. Okay, so Parkinson's disease being an extrapyramidal system disorder, what are the abnormal findings we can expect? Two important things here. One is bradykinesia, second is rigidity, and as a third component, the tremor. So this three cluster of symptoms, bradykinesia, rigidity, and tremors, are the hallmarks of Parkinson's disease. Bradykinesia, rigidity, tremor. What is bradykinesia? Brady means slow, kinesia, slowness of movement. So these patients have slowness of both voluntary and involuntary movements. What are the voluntary movements? All the voluntary movements that we do. Involuntary movements, blinking of your eyes, that slows down in these patients. Number two, when they're walking, the arm swing slows down. Those are all involuntary movements. Both of them get slowed down. And there are some clinical manifestations that arise because of the development of bradykinesia. Number one, in Parkinson's disease, we say they have mask-like faces or expressionless face, which is also addressed as hypomimia, right? You know, miming that you do in your college days, like mime skits, basically trying to communicate with the expressions or body language without the use of words or spoken language. That is what your miming act, right? So hypomimia means decrease in expressions. That is what is mask-like faces. But do you think they have lost the emotional abilities and connect, and that is why they are having the expressionless face? The answer is no. There is slowness of the movement of muscles of facial expression as part of bradykinesia. So you tell them a good news or a bad news, the expression will appear on their face way later, and by that time you would have felt that, okay, they are not responding to my comments or my suggestion. That is why to us it appears that they have lost expressions. Okay, that is one. Second, because of the bradykinesia, they have difficulty in initiating a movement. Whenever you ask them to get up and start moving, they have difficulty or slowness, and it can also contribute to other problems. We will discuss that later. Now, the number two hallmark is rigidity. So what is rigidity? Increased tone of the muscle. right? We have already discussed about the difference between the spasticity and rigidity. Rigidity is basically where the increased tone is such that throughout the range of movement, the resistance is equal, same throughout the range of movement. That is what we call as rigidity. In spasticity, the resistance is more initially, and as we persist with the movement, the resistance is giving way. That is spasticity. Spasticity is a feature of pyramidal tract lesion. Rigidity is a feature of extrapyramidal tract region. Now, Parkinson's disease being an extrapyramidal disorder, we will have rigidity. Now, this rigidity leads to various clinical manifestations. So, Ranjith sir was talking about, when I hear about Parkinson's disease, the first thing that comes to my mind is stooped posture. Why there is stooped posture? The rigidity in Parkinson's disease is, I say, axial and extraaxial. What does that mean? It is affecting your limb, that is extraaxial muscles. It is also affecting the core of your body, that is axial muscles. So here it is both axial and extraaxial, and the axial rigidity is more on the anterior group of muscles than the posterior group of muscles. So imagine the front of your muscles, your rectus abdominis, your chest muscles have increased tone. That means they're more contractile in comparison to your posterior muscle. So what will happen to the posture? You develop a bent posture. You start leaning forward. Once you start leaning forward, what happens to the center of gravity? It is shifted forward. So when center of gravity is shifted forward, when you're walking, imagine yourself walking bent forward. If you have a tendency to fall forward, right? And to escape that fall, what do? You try to accelerate. If you're not able to relate, then you might have done this exercise in kids, right? When there's a log of wood or a small bridge, and you try to walk on that, and you can only place one feet at a time. When you have a tendency to fall, you try to complete that stretch of walk by running forward, accelerating, right? This is what we see in Parkinson's disease patients. So when they start moving, initially they have slowness, but they keep accelerating to avoid falling forward. And this is what we call as they take short shuffling steps and try to escape falling. We call it as short shuffling gait or festinant gait, which is resulting because of this hypertonia or rigidity, right? Short shuffling gait or festinant gait. That is one thing. Then second thing, they have the stooped posture. When I see a patient who is 70 years or 80 years and has a stooped posture, another differential diagnosis comes to my mind. Does he have any spinal deformity? Possible, right? At that age, multiple level spinal fractures could have happened because of the osteoporosis, and that would have caused the true deformity of the spine. Is it possible for me to clinically differentiate between the stooped posture of Parkinson's disease and the true spinal deformity? Yes, that is also possible. How is it possible? All I have to do is make the patient lie down on a flat bed. If the patient lies down on the flat bed, I will look at whether the curvature of the spine disappears or it remains curved. If it is a true spinal deformity, it will persist. But if it is because of the Parkinson's disease, increased muscle tone or rigidity is not so much that it can overcome the effect of gravity. So as soon as the patient is lying down flat, the gravity will take over and the bent spine becomes straight. And there is a name for this sign. We call it as camptocormia, camptocormia, camptocormia. Camptocormia, there was a question in the past asking, where do you see camptocormia? It is seen in patients with Parkinson's disease. What is it? The disappearance of the bent spine on making patient supine. That is camptocormia. Okay, so that is about the rigidity. Now coming to the third symptom, tremors. Whenever we describe tremors, there are some templates to use. Number one, whether the tremor is affecting the proximal group of muscles or distal group of muscles. Number two, whether the tremor is bilaterally symmetrical or asymmetrical. Number three, whether the tremor is present at rest or it is on movement or it is because of particular posture. Right. So the first point, whenever you discuss any neurodegenerative disorder, we have to understand that neurodegeneration starts in one cerebral hemisphere and then eventually involves the other cerebral hemisphere. And by the time the second cerebral hemisphere where the neurodegeneration is catching up, the first cerebral hemisphere would have progressed further. So most neurodegenerative disorders, whatever symptoms you see, are generally going to be asymmetric. Symmetry goes against the diagnosis of Parkinson's disease. So if I have someone who has tremors, which is pill rolling, but perfectly symmetrical, I would rather think of drug-induced Parkinson's disease, because drug won't differentiate between your right and left substantia nigra. But the neurodegeneration will probably start on one side and then eventually involve the other side. So that is a potential clue to differentiate between drug-induced Parkinson's disease and the true idiopathic Parkinson's disease. One, okay, asymmetry. Number two, you have already known that the Parkinson's disease causes pill rolling tremors. So pill rolling is the act of your fingers, right? So that is distal group of muscles. The muscles away from the core of the body or the umbilical, those are distal. So the The tremor of Parkinson's disease is distal more than proximal. So you might ask me, sir, give me an example for a tremor which affects the proximal group of muscles. For that, I'll give you a clue of a disease. You should tell me what disease I'm talking about. There is abnormal copper metabolism. The patients might develop neurodegeneration. Patients might have this particular tremor called as wing beating tremor. So what disease I'm talking about? Okay, so in those patients, you see a particular ring on the limbus in the cornea. You call it as KF ring, right? So what disease I'm talking about? The Wilson's disease. So in Wilson's disease, you have a tremor called as wing beating tremor, which is affecting mainly the proximal group of muscles. And that is a postural tremor. So when you ask the patient to hold this posture, the muscles around the shoulder joints start moving. So they have this wing beating tremor. That is a classical example of proximal tremor. That is also an example for a postural tremor. Now in Parkinson's disease, the tremor you have is rest tremor. The tremor is present at rest. It might decrease or altogether disappear when the limb is moved. It will reappear once the resting posture is assumed again. A rest tremor affecting the distal group of muscles, asymmetrical bilaterally, will go in favor of the Parkinson's disease. So these are the cardinal symptoms of Parkinson's disease. Now coming to its diagnosis, how can we make a diagnosis of Parkinson's disease? Number one, the diagnosis is purely clinical. We don't need any imaging, and definitely we don't need a biopsy. The diagnosis is clinical. For the diagnosis, we follow the Movement Diseases Society MDS criteria. MDS criteria. So the criteria says any patient who has got bradykinesia plus one of the following two symptoms can be said to have Parkinson's disease. So bradykinesia is the most important symptom. There was an MCQ in one of the INI SS exam asking you which of the following is considered as a mandatory symptom for diagnosis of Parkinson's disease. The answer is straightforward. It has to be bradykinesia. Bradykinesia plus either tremor or rigidity. One of the two, tremor or rigidity. So if you have bradykinesia and tremor, well, you can make a diagnosis of Parkinson's disease. Or if you have bradykinesia and rigidity, you can make the diagnosis of Parkinson's disease. If at all you have ended up doing a brain imaging in Parkinson's disease, you see a specific image finding, which can be an image-based question. You don't need it for diagnosis, but like Parkinson's disease is elderly, 70, they might develop stroke or other symptoms, and you might end up doing an MRI. So what would I see if I've done MRI? I would see something called as loss of swallow-tail sign on MRI. Loss of swallow-tail sign. What is this? You may be familiar with a bird called as a swallow bird. If you don't know, you can just Google it and you will get nice, beautiful images of beautiful birds. The swallow bird, it's a large genus. Now, when you look at its tail has a bifid appearance. It looks like an inverted V. It has a bifid appearance. Our substantia nigra in normal condition, like you're seeing, there is an image with the arrows pointed out. It's a normal image of the substantia nigra. Okay, so on the corner, you can see one brain image where there are arrows pointing towards the normal substantia nigra. So the normal substantia nigra has bifid appearance, right? Both the sides, you can see that it looks like inverted V. Now, in patients with Parkinson's disease, the substantia nigra is going through neurodegeneration and this bifid appearance is lost. So in the middle of the screen, you're seeing an image where the dark area that you're seeing, that is the substantia nigra, which doesn't have that bifid appearance. It has become one, right? This is the abnormal finding, and this is called as loss of swallow-tail sign. And just to correlate, right, we are in an integrated session. Just to correlate, I've already told you neurodegenerative disorders are almost always asymmetrical. So when you see in the center of the image, the degeneration is affecting the right side more than left side. Can you notice that? Right side, the substantia nigra is stunted in size in comparison to left side. Both the sides there is loss of bifid appearance, but right side it is smaller. The substantia nigra is smaller than left, right? It goes on to reinforce our understanding of the neurodegenerative disorders, right? What we call this sign as normalcy is swallow-tail sign and abnormal is loss of swallow-tail sign. Loss of swallow-tail sign is an extremely specific finding in patients with Parkinson's disease. We don't need it for the diagnosis, but you should be aware you might get an image-based question. Okay, so this is about the diagnosis of Parkinson's disease. What have we learned? The diagnosis is clinical. We need bradykinesia as a mandatory symptom, and either tremor or rigidity should be there. Both are there, well and good, right? So we make a diagnosis of Parkinson's disease clinically, and then once we have made the diagnosis, then comes the question of the management. It's a neurodegenerative disorder. Can we do something to slow down the progression? and how can we improve patient symptom. Patient has tremor, patient has bradykinesia, and patient has rigidity and its consequences. So to understand the management of Parkinson's disease, I'll pass the baton to Ankit sir, and he will give us an idea about the drugs available at our disposal. Over to you, sir.
So before starting management, Ranjith sir were discussing about some toxins which can lead to Parkinson's disease. And unfortunately for you students, this MCQ was asked some 2-3 years back. Can we name any toxin which can lead to Parkinson's disease? Yes, there is an answer for it. The answer is MPTP toxin. Now remember, some people say it's an environmental toxin, but being a pharmacologist, I would say we use this toxin to induce Parkinson's disease and develop new drugs. So remember, this word is already written in your pharma books. It is not something which I have taken from Google and teaching you. It's written in your pharma books.
I hope not for patients, sir.
Yes, sir. Yes, it's basically for animal research, sir. For most of the neurodegenerative disease, obviously, sir, we can't, due to ethical reason, we can't develop the drugs for Alzheimer and Parkinson's by inducing that disease. So first, here comes the role of animal studies, basically. Now, just to understand how we can simply remember the drugs of Parkinson's disease, as Santosh sir has said you, we all know that there is a reduction in dopamine level. But Santosh sir said that dopamine is not the only neurotransmitter which is involved in Parkinson's disease. Yes, there is involvement of glutamate. I will tell you a drug which acts on glutamate. There is an imbalance of acetylcholine. There is an imbalance of adenosine. So when chemical word comes, pharma becomes a little bit important and difficult to learn also. So for beginning, just remember one thing. We know that in Parkinson's disease, there is decrease in dopamine level. Yes. So remember, when dopamine level reduces, can we say relatively the acetylcholine level increases? And we all know acetylcholine causes muscle contraction, which is one of the reasons there is a rigidity in cases of Parkinson's disease. Now remember, what we can do, how we can treat this Parkinson's disease. So there is an imbalance. The first thing what we can do for the treatment is, we can again restore the balance of dopamine. We can increase the level of dopamine. I will tell you the drugs like levodopa and many other drugs. The second thing what we can do is, can we give anticholinergic drugs in the treatment of Parkinson's disease? The answer is yes. There are certain areas or certain symptoms which are not controlled by levodopa, but just by increasing the level of dopamine. Somewhere we have to reduce the level of acetylcholine as well. So let's first see what are our various drug targets. So if we see, this is a, let's say, substantia nigra pars compacta. Let's say from here the motor symptom starts, as the sir has explained you. And this neuron has stopped producing dopamine. So there is a dopamine deficiency. So what we can do, can we give dopamine directly from outside? Can we give dopamine directly from outside? The answer is no. The reason is very simple. Dopamine cannot cross blood-brain barrier. So hence, we have to make a precursor or a prodrug of dopamine. The drug name is levodopa. So hence we give a drug levodopa. So can you tell me what is the advantage we have of levodopa over dopamine? Yes, levodopa can cross blood-brain barrier. Now this levodopa will enter into the neurons of substantia nigra pars compacta. And inside the neurons, we have an enzyme known as dopa decarboxylase enzyme. This dopa decarboxylase enzyme will act on levodopa and it will convert levodopa into dopamine, and this dopamine will be released. Agreed? So this is the strategy which we usually employ. Now, when this dopamine is released, remember it acts on other neurons, basically striatal neurons or below thalamic neurons are there, which is not important to remember. But the important point is that this dopamine acts on D2 receptor. And the point you should remember is that dopamine is an inhibitory neurotransmitter. Because it's an inhibitory neurotransmitter, it causes muscle relaxation. Hence, the level of excitatory neurotransmitter increases, that is acetylcholine, which causes muscle contraction, which can lead to rigidity. If the muscles are rigid, it will be difficult to move, bradykinesia, and very rigid muscles will have resting tremors like this. Agree? Now, when this dopamine is released, after some times, this dopamine gets degraded by MAO enzyme and COMT enzyme. So if you have understood this simple story, all the drugs for Parkinson's disease are now a cakewalk for you. Now, what we can do? The first drug we discussed is levodopa, and undoubtedly, from many decades till now, levodopa is the drug of choice for Parkinson's disease. Remember this point. The reason is it is the most effective drug. It is highly cost-effective drug also. It's very cheap. The newer drugs are more expensive. Second thing, what we can do is, can we directly stimulate D2 receptor by giving D2 agonist? Yes, we have drug D2 agonist like ropinirole, pramipexole, etc., which I will be teaching you. The third thing what we can do is we can inhibit this MAO and COMT enzyme. If we inhibit this MAO and COMT enzyme, it will increase the level of dopamine inside our brain. Hence, we have MAO-B inhibitor, we have COMT inhibitors, the enzymes which are responsible for degradation of dopamine which is produced. Now, let's talk about the first, the drug of choice for Parkinson's diseases, no doubt levodopa, which is also known as L-dopa. And why we are giving? We know the reason. Levodopa can cross blood-brain barrier, and inside the brain, it gets converted into dopamine. Hence, it's a prodrug. It gets converted into dopamine by which enzyme? Dopa decarboxylase enzyme. Now, it's very simple for you to remember. Now, don't you think dopamine is also produced outside the brain also? So don't you think this levodopa can produce dopamine in the peripheral organ or outside the brain? Do you want that? Just tell me, do you want that levodopa should be converted into dopamine outside the brain? The answer is no. Hence, we inhibit this dopa decarboxylase enzyme in periphery, so that this levodopa should not be converted into dopamine outside the brain. And that is why peripheral dopa decarboxylase inhibitor, the drugs are carbidopa, the most commonly used, and benserazide. Can we say if we combine levodopa with carbidopa, it will inhibit the peripheral conversion of levodopa into dopamine, and more levodopa will be available to enter into the brain. So don't you think it will produce synergism? Because it produces synergism, this combination is also known as syndopa. Now you know the reason why it is known as syndopa, because it's a synergistic combination. But remember one point. We must have heard that in tuberculosis, we always combine vitamin B6 with isoniazid. So yes, in TB, we always give vitamin B6 with anti-tubercular drug. But remember, with levodopa, we never give vitamin B6, because vitamin B6 is opposite of carbidopa. Carbidopa inhibit peripheral conversion by inhibiting peripheral dopa decarboxylase. But vitamin B6, it increases peripheral conversion of levodopa into dopamine. That is why it increases the side effects of levodopa outside the brain. Never combine vitamin B6 pyridoxine with levodopa. Last point. Remember, dopa just does not produce dopamine. No, it has other actions also. Dopa can also be converted into melanin pigment. That is why levodopa should not be given in which cancer or which tumor or whatever the word Ranjit sir says is fine. You should not use levodopa. It should never be given in melanomas. Remember, because levodopa can increase melanin production. So let's talk about the peripheral side effects of levodopa, which can be reduced by carbidopa. So first is puking. Puking means nausea and vomiting, because when levodopa forms dopamine, dopamine acts on CTZ area of the brain, which is outside the blood-brain barrier. It can lead to vomiting. How to treat it? Give dopamine blocker domperidone. Domperidone blocks dopamine receptor on CTZ area. It is a drug of choice for levodopa-induced nausea and vomiting, which is the most common side effect of levodopa. Now, after that, it acts on blood vessel, produces vasodilation and hypotension. It causes mydriasis in eye, and on heart, it can lead to arrhythmias. Because it acts on D1 receptor, beta 1 receptor, and alpha 1 receptors, which we have discussed in autonomic nervous system. Now, remember one point: any drug that produces mydriasis is absolutely contraindicated in glaucoma. Because if you will produce mydriasis, the tubercular meshwork will become blocked, because it leads to some iridocorneal angle blockage, which we will discuss in glaucoma. So just remember for the moment, any drug that produces mydriasis should not be given in glaucoma, and levodopa produce mydriasis. As simple. Now, these were the peripheral side effects which were seen outside the brain. Now, what side effect we see inside the brain? Now, the first thing is very simple. If in basal ganglia we don't have dopamine, there is dopamine deficiency, a person becomes rigid, absolutely fine. That means there is slowing of movement, bradykinesia. But just imagine you have given levodopa and there is excess of dopamine in basal ganglia. So till now the person was not moving. You have given levodopa in excess dose. A person will start dancing. So this is abnormal, excessive movement can occur with levodopa, which is known as dyskinesia. That is abnormal or excessive movement because of excess of dopamine in same area, basal ganglia, where dopamine was deficient. Now, this is a big problem. How we can prevent this dyskinesia? Just like rigidity, even dyskinesia is functional or motor impairment. It can lead to the person will not able to do the day-to-day activity. Hence, we have to develop drug for levodopa-induced dyskinesia. There are two drugs which have been approved. The first one is an antiviral drug also, amantadine, and the second one is levetiracetam. And these are very commonly asked MCQs from you students. So for levodopa-induced dyskinesia, combine them with amantadine or levetiracetam. Nowadays, we are using levetiracetam more. Now, so this was basal ganglia. Second thing is cortical area, mesocortical area. In cortex, we think, we have thought, we have wonderful experiences. But just imagine if there is excess of dopamine, you will have excess of wonderful experiences without having actually you're feeling it. Or in simple word, I can say, you will have abnormal perception, that is psychosis. So excess of dopamine in cortical area can lead to psychosis. Agreed? Now to treat this levodopa-induced psychosis, we have to give certain antipsychotic drug that should not interfere with dopamine receptor. And 3 antipsychotic drugs have been approved for levodopa-induced psychosis: clozapine, quetiapine, and pimavanserin. Then in medullary area, where all impulsive or primitive functions you can see happens, a person will become impulsive, like impulsive gambling, hypersexual. So all the primitive functions like sexuality, impulsive disorders can start from medulla. So remember, if a person is taking levodopa, just beware from that person. He is hypersexual, he can catch you. So just stay away. So remember, all these side effects of levodopa are not reduced, rather increased by carbidopa. The reason is carbidopa promotes the entry of levodopa into the brain. So now the last point is, let's say a patient of Parkinson came to us and we started levodopa. What happens after some years? The effect of levodopa reduces. Why? Very simple. The Santosh sir has told you that Parkinson's disease is a neurodegenerative condition. Let's say initially there were 100 neurons. When you give levodopa, it entered into the neuron and formed dopamine. And let's say this dopamine acted for 24 hours. The person was fine. Now, after 5 years, because it's a neurodegenerative condition, now only 10 neurons are remaining. Now, if you will give levodopa, can we say very less amount of dopamine will be produced? And this dopamine now, it will act just for 2 minutes. So just imagine this last stage. When you have given levodopa, a rigid person will become normal. Agreed? On phase. And after some time, the person will again become rigid. So can we say it is just like a switch? On means person became fine, started moving, and suddenly the person become off, back to the rigid stage. So this is known as on-off phenomena, which is seen with levodopa in late stages of Parkinson's disease. So if a person came with late stages on-off phenomena, what is our agenda? Can we say on means improvement occurs? Off means the person again become rigid. So what we have to do? We have to prolong the on phase. We have to prolong the on phase of the person, and we have to rescue that patient from off phase. First, let's talk about how a rigid person in off phase came to you in emergency, who cannot eat anything, cannot even swallow his own saliva. Can you give that patient an oral drug during off phase? The answer is no. So we have only one injectable drug in Parkinson's disease. And the drug of choice to rescue the patient from off phase is apomorphine injection. Apomorphine is directly acting on dopamine receptor D2 agonist, which we just learned. Now we have to prolong the on phase. Hence, we have to combine certain drugs with levodopa. Now, can you tell me levodopa by forming dopamine was degraded by which two enzymes? I told you, MAO enzyme, COMT enzyme. So the first drug we give is COMT inhibitor. It will increase the level of dopamine, and the person will remain in on phase for very long duration of time. And these drugs, they end with the word 𝐀𝐻𝐿. The first drug you will start is Anticholinergic, but 𝐊𝐶𝐻𝐿 you will give as a last resort when no other option is there, because 𝐊𝐶𝐻𝐿 is a drug of last resort. It is a highly hepatotoxic drug. Other drug which we can give is MAO-B inhibitor. These drugs, they end with the word gilene. Seligiline, rasagiline are irreversible inhibitor. A new drug recently asked in INI-CET exam, safinamide is a reversible inhibitor. But few years back, from tea and coffee, we obtained one drug. The drug name is istradifilene, similar to theophylline, which is found in tea and coffee. And it is an adenosine blocker. And adenosine, it acts as a co-transmitter with dopamine. Both adenosine and dopamine are released together. And adenosine promotes the action of dopamine in some way. We don't have to go into that detail. Just remember it's an adenosine blocker. A new drug to prolong on phase is adenosine. Fine. Now, amantadine, which I have told you, was given for levodopa-induced dyskinesia, blocks glutamate receptors from striatal area.
There's a question for you from a student. Why don't we never give pimavanserin in hospitals for maintenance? Why is that so?
Pimavanserin, first point, sir, it is not available in India.
Okay, NEET PG, I think you got your answer. That might be the reason.
Second thing is, pimavanserin is a very good drug. It is the only antipsychotic we have which does not act on dopamine receptor. Rest, any antipsychotic we take acts on dopamine receptor. That is why pimavanserin is specifically approved for psychosis, which is seen in Parkinson's disease. Because any other antipsychotic will block dopamine receptor and aggravate Parkinson's disease. Second thing is, with pimavanserin, just see the cost of pimavanserin and availability in India. Then we will get back on Telegram and chat together. Next point, amantadine, it is also an antiviral drug. Can any student who can tell me against which virus amantadine was developed? Yes, it's influenza virus, and it is one of the drug which can be given in swine flu, but now we have new drug for swine flu as well. It is not the drug of choice. The side effect you have to remember, which is commonly asked, is livedo reticularis. It suddenly leads to vasodilation because of its dopamine action. Livedo means some purplish kind of a thing. Reticularis means net-like pattern. So you can see this purple net-like dilatation of blood vessels on skin. So this is livedo reticularis caused by which drug? Amantadine. Lastly, last slide of the day from pharma side is whatever I have told you. Let's summarize everything in 1 or 2 slides. Just let's finish Parkinson's disease. Now just imagine, sir said that motor symptoms are not the first clinical feature of Parkinson's disease. No, functional impairment is not. Initially, there is loss of smell and something. Let's say a patient of Parkinson's disease came to you without any motor symptom, without any functional impairment. Which drug you will start? The answer is rasagiline. Because rasagiline, gilene means MAO-B inhibitor. It is the only neuroprotective drug we have for Parkinson's disease. Now, later on, a patient came with symptoms like rigidity, tremors, bradykinesia. That means there is functional impairment. So if there is functional impairment, the drug of choice is levodopa. And yes, you can start D2 agonist, but D2 agonists are only given in mild cases. But if there is severe motor impairment, the most effective drug we have is levodopa. Now we know levodopa has certain drawbacks. To overcome those drawbacks, we combine other drugs with levodopa. First, to inhibit peripheral degradation, which drug I have told you? Carbidopa, benserazide, peripheral dopa decarboxylase inhibitor. Second point, levodopa leads to excessive movement. Which drug we give? Amantadine, levetiracetam. Next point, in late course, there is on-off phenomena. To promote on-phase, MAO inhibitor, COMT inhibitor, and T-coffee stradifilene. To rescue the patient from off position, apomorphine, only injectable drug, because patient cannot take a drug orally during emergencies. To prevent vomiting, domperidone. To prevent psychosis, 3 antipsychotic drug. And lastly, levodopa can control all symptoms of Parkinson's disease except one, where levodopa is not very effective. Is it rigidity? Is it bradykinesia? Or is it resting tremors? Remember, levodopa is not a good drug to control resting tremors. So if levodopa by increasing dopamine level cannot control resting tremor, can you think what we can do? Can we reduce the level of acetylcholine? Yes. So we give anticholinergic drugs like benzhexol with levodopa to control resting tremors in primary or neurodegenerative Parkinson's disease. But there is a different entity which sir has told you, where you have symmetric tremors. So I told you some drug-induced Parkinsonism. Yes, a drug-induced Parkinsonism means there is fall in dopamine because of dopamine receptor blockage. Here, you cannot increase the level of dopamine because dopamine receptors are already blocked. You cannot increase dopamine level by giving levodopa. What we can reduce? We can reduce the level of acetylcholine. Hence, the only drug we have for drug-induced Parkinsonism is anticholinergic drugs. Remember, here only one drug, anticholinergic like benzhexol. You have to remember, also known as trihexyphenidyl. But in hospital settings, we very commonly use promethazine, cheap, sasta, आसानी से मिलने वाला drug. Now, which drug causes drug-induced Parkinsonism? Which block dopamine receptor in brain? The first class of drug is antipsychotic and one anti-emetic drug, that is metoclopramide. 2 drugs you have to remember, and the drug of choice is benzhexol. Not available, go with promethazine. Comes with the brand name Phenargan. Phenargan suna kisi ne? Phenargan injection, Phenargan syrup, which is generally given when a child is crying and we want that child to sleep, we give Phenargan, but it has another use also. So this is all from my side. Santosh sir, Ranjit sir.
Okay, just few more points to add. So for whatever we have discussed, so there's a standard template, as I've already told you, to remember neurodegenerative disorders, especially with respect to management. Ask yourself, is there any drug which slows down the progression of the neurodegeneration? We have thrown some light on such thought process. When we were talking about Alzheimer's disease, we were trying to block the amyloid formation or deposition in the neuron. So remember which drugs, right? Sir has already told you about two drugs which are pretty recently approved. They might go a long way in reducing the progression of Alzheimer's disease, or they may fail in the future. As of now, we don't know, but these are recently approved drugs. With respect to the Parkinson's disease, so told you about one drug which is neuroprotective, which can to some extent slows down the progression of the neurodegeneration. What is that drug? You should be able to remember by now, because Sir has already told you, which is already discussed within the classes of drugs used for the pharmacotherapy of Parkinson's disease. So always keep that template in mind. Think about slowing down the progression of neurodegeneration. Think about the symptom management. And when you're thinking about symptom management, the side effects and how to overcome that side effects, all of that Ankit sir has given you a beautiful overview. Okay, so I think we have got a fair bit idea about how to approach a case of Alzheimer's disease as well as Parkinson's disease when it comes as a question in your exam, as well as if you have a patient walking into your OPD during your internship. So with this, we will sign off for today. In the next session, we will try to bring in questions where you have to kind of clinically oriented questions where you have to apply what we have learned in the previous session, so that will give you a mental work or a kind of rehearsal of whatever we have learned in the previous session. So with that, we will probably wind up today's session. Please stay connected with the PW MedEd channel, and we will be coming out with more such interested integrate session. Sir, Ranjit sir, you have anything to add?
I was more of a spectator here, and I was learning and revising many things. One thing which I can still remember from the treatment of Parkinson is the resting tremor and the anticholinergics used in the Parkinson's disease, drug-induced Parkinson, because that MCQ is staying there for, it's staying forever. And
From
I
our times.
stay forever as well, right? So thank you everyone for your time. And like Santosh said, that we'll be coming up with more sessions. Tomorrow, I think you'll have more of integration with surgery, neurosurgery, and orthopedics as well by the end of this week. And we'll give more clinical minutes to solve with more teachers live. So NExT or NEET, don't worry. It's about the same disease. We'll present in a different way and we'll learn together, right? Thank you. Thank you, everyone. Good night. Good night, sir.
Thank you, everybody. Have a good night. Thank you.
Good night.